I will express my personal opinion regarding the best practice in antifungal management. I also sincerely invite everyone to think about your thought regarding the best practice during the QA section. We first think about the antifungal management. Is it limited to the use of antifungal agent, or more broadly, so-called antifungal stewardship, or more broadly, include infection prevention and control? The best practice nowadays is not just the ideal world we wish in our wish list. I think it should be think about the real world complexity and challenge, as well as consider its cost-effective way to get the following purpose. Why? No matter where you are, which country you are, or which hospital you serve, we always facing the limitation in resource. So it is very important to be practical, but work together to improve the patient outcome and hopefully to decrease the cost. And if possible, try your best to reduce or mitigate the drug-related toxicity or any drug-drug interaction. Hopefully, we can work together to curb the increasing antifungal resistance. You all are very familiar with these three purposes, but for bacteria, the drug resistance might be, and very likely, more important than the cost of antifungal management. But in daily practice, every physician facing a patient with critical ill, shock, very suffering, we anticipate a faster, simple, more efficient way to help our patient, but is it feasible or achievable? We can think together. But according to our assurance mission, is this possible? We're facing the hidden killer from a population level. They underestimate their impact. They underestimate during each event because the difficulty in diagnosis. However, we're facing the expanded spectrum of patients at risk with various presentations and more fungal pathogen. Especially, it's very challenging we're facing at the bedside. The fungus isolated from clinical specimen might not be the true etiology of the causing the patient ill or sick or shock. It might be just colonization or even contamination during collected specimen or processing the specimen. On the other hand, a negative result of specific test might not exclude the possibility of the infection. Although we have substantial or increasing burden regarding the incidence, mortality, mobility, or invasive fungal infection, due to the growing pool and higher survival of susceptible population, due to many reasons. However, we have existing treatment options are limited or not affordable. More complicated, we have emergent drug resistance. However, we facing the gap exists in real-world daily practice, according to these two publications, as well Arun and Sharon mentioned. More complicated is we have very complicated, as we learned yesterday from our faculty, demonstrate different, in very heterogeneity underlying. Even we more familiar with the mindless ablation therapy, we physicians more alert for the low cell count neutropenia, but we are not, sometimes not very sensitive to the immune suppress following some target therapy given several months ago. And it's more complicated with the comorbidity and all the risk before he transferred to your hospital. We have more and more new drug and the very complexity of interaction. We also think about the One Health issue. We estimate the risk of drug resistance not only to their prior use. We need to think of the exposure risk and the agriculture in your country or in your site. So I not yet found any magic bullet or magic solution. So I encourage everyone to back to the basic principle. The principle of infectious disease for many decades. It's a precision medicine. We need to think about it is infectious disease due to fungus, due to specific fungus, or down to the species level. We should take into account the personal characteristic. We consider the PK/PD, and we need to facing the, you practice in a working day or during the long weekend. Because during the long weekend, a lot of tests are not available. In addition, take into the consideration of continuation of invasive fungal infection. From inoculation or colonization to infection, we can detect the fungal pathogen to tissue invasion. The key intervention measure might vary by different period. We can start from prevention or be alert and detect early to the therapeutic. Although we had accumulated more and more evidence, all this evidence, the majority are limited to very high risk population, and the majority of them are pathogen specific. However, even this URTCMG criteria for case definition, they emphasize this is for research. When you initiate antifungal agent, they might not yet fulfill the criteria, but it did not exclude the possibility of invasive fungal infection just because the result of testing or the image finding not yet fulfill the criteria. In addition, the case definition, I think the majority of you are very familiar with this figure. It demonstrates the days, the immunosuppression, the course, and the fever as one of the presentation, or might be the only one of symptom sign, highlight the possibility of the invasive fungal infection. But the majority are the case definition. They incorporate host, clinical, and mycological as a composite endpoint, composite case definition. The most important idea, the novel breakthrough, is integrate diagnosis and the antifungal strategy. This figure demonstrates the number needed to treat based on different antifungal strategy. You can see the prophylaxis and empirical therapy that a lot of infected individuals receive exposed to antifungal agent. In mind, we need to think about the balance regarding the benefit and the potential hazard from the drug-related adverse effect or the cost. In addition, many antifungal have drug-drug interaction might interfere the treatment of their underlying disease. So it should be very careful to evaluate and the balance between them. On the other hand, we also concerned regarding the delay and the difficulty in diagnosis of invasive fungal infection. Nevertheless, the Aaron and co-author reviewed 70 studies and showed that the diagnosis-driven antifungal stewardship did have some impact regarding shortened the time to target therapy, length of empirical therapy, also had impact on the outcome, included antifungal consumption, cost saving, mortality, and length of stay. However, the majority of study is from European country or American country. Few are from Asia. Why? Just because we are a lot unmet need in Asia. In this review, we summarize although we work together, try to improve the diagnosis. And this is why we, FWG, we working together since 2009. However, the selected diagnosis tool, although they have probe, may facilitate early and more sensitive diagnosis. However, there are still several drawbacks or challenges. So this is a reason why we emphasize the importance of the availability, accessibility, performance, and turnaround time of the diagnosis tool in your facility, in addition to other metrics to determine the optimal antifungal strategy in your institution or for your patient population or individual patient. This metric including epidemiology, diagnostic tool in facility, accessibility to healthcare setting during high-risk periods, as well as the therapeutic factor, cost effectiveness in our Taiwan guideline several years ago. Regarding the epidemiology, when we assess the risk for individual patient, we take into consider the incidence of the invasive fungal infection in your country, in your geographic location, or in your institution, as well as the individual risk before immune suppression therapy or after, might be 15 days post-treatment for some regimen, or when patients have symptom onset, which suggests of invasive fungal infection or others. We, with Taiwan guideline, adopt NUSIS suggestion, so-called a risk-adapted and the timing adapt dynamic antifungal strategy. This needs very important risk assessment. When patient diagnosis of hematology disease or others, we need to conduct a pre-treatment risk assessment. It's not limited to his or her primary disease. We need to consider their underlying condition and the pharmacological intervention, as well as the comorbidity, other factor. But the very neglect issue is the environment factor. It is very difficult, and you very commonly neglect during our risk assessment. This is very important because not just risk assessment, during this approach, we also educate patients. This is so-called patient empower, educate them to reduce the risk further. Otherwise, it will compromise your antifungal prophylaxis, your effort. So this is the so-called environment risk factor for mold-related infection in immunocompromised host. It is for risk assessment, also for patient education, for risk reduction. I'm very happy to see this publication. This is from German Society for Hematology and Medical Oncology. They include non-pharmaceutical intervention in their recommendation to prevent infection, fungal infection. That means the risk reduction is not limited to antifungal prophylaxis. So this is the healthcare setting. Healthcare worker, we can help our patient. In addition, we ask patients they do something for their own. The risk vary by the stage of the disease. We take this recent publication to demonstrate, although rare, the invasive aspergillosis in liver transplant recipient. As we learned from Dr. Tan's mention, in cirrhosis liver and others. Especially for asper, if you search in tertiary care center, remember, and very important, review the medical history before transplantation, because some risk factor already there before, during the end-stage liver disease, or during the operation period, because the environment factor, as well as the post-transplantation. We more familiar with the steroid, but steroid might not use for underlying disease, might be for prevent transfusion reaction or other reason. The most neglected one is the iron. For many years, I found physicians are usually not properly interpret the anemia and give patient iron supplement. The iron is the growth factor for Aspergillus and for many pathogenic organisms. So you give the iron supplement, but patient not iron deficiency, but causing the negative side. For diagnosis, no matter what you have, try to optimize what you have to get better diagnosis. But very important is the 6 elements we emphasize in this paper. Be aware, be alert. This need to educate patient as well. And be accessible to tests needed, and the sample adequate for test. Result, we emphasize, we need work together from the lab part, because results should be available in timely manner. And of course, be affordable for repeat diagnosis, especially for the test is monitored during the high-risk period. Nowadays, we have more and more diagnostic tool. This is for different purpose. One is identify, detect the infection, and identify to species level if possible, as well as the risk stratification, prognosis prediction, and response evaluation. The most important one is detect and species identification. As we learned from our faculty lecture that there's no one size not fit all, because the in vitro susceptibility vary by genus, sometimes to the species level. You need to familiar with, because some sample collection need to send to the central lab in your hospital or outside your hospital. They will compromise the turnaround time. So ideally, we prefer some rapid test at the point of care. But there's a strength and limitation of each test, no matter the NGS or something. And all these tests, some is pathogen specific, or pain fungus, or syndromic testing. You need to, when you integrate diagnosis, you need to familiar with the strength and limitation of all these tests. So this is a reason why we emphasize the diagnosis as among 5 elements of antifungal stewardship. With the appropriate and the timely diagnosis, we know the focus, we know the etiology, and if possible, based on epidemiology or the in vitro testing for the isolate, we can determine the optimal drug dose and facilitate the de-escalation later. This is the publication explain how consider for individualized selection of optimal agent based on the host factor, drug, infection, and pathogen. Here I would like to explain, because when you review the pathogen-specific guideline, you will see the primary agent and alternative agent. This is, we describe in Taiwan guideline, emphasize that if there's some local resistant profile, before patient data are available, or patient is allergic, or drug interaction, you may consider proactively to select the alternative agent, not just wait of refractory or breakthrough infection. This is so-called reactive approach to choose the alternative agent. So I will, citation of the author emphasize the incorporate so-called AID model to combat the antimicrobial resistance, that is integrating antimicrobial infection prevention and diagnostic stewardship. So back to the patient, back to the continuation of invasive fungal infection. Before immunosuppression therapy, we need to sincere risk assessment. You may consider active screening, whether there's an infection or something, or periodical monitor while a patient is at risk, or during when onset of any symptom, you conduct the diagnosis on demand and choose the appropriate antifungal. Maybe you think it's too complicated. Maybe you can call for help, call ID doctor. This systematic review favor ID consultation, have positive impact regarding the mortality. So in conclusion, not yet any magic bullet. So I define the best practice in antifungal management as smart use of right weapon, that is integrated diagnosis and therapeutic, for the right patient at the right time through timely adjust risk assessment, risk reduction, and multidisciplinary collaboration. Thank you for your attention, and welcome, Phil.